Dr. Titiyal, who would be speaking on
some of the
posterior polar cataracts, tips and tricks to enhance.
Because Abhay has just covered, I'll take you to some other areas. So I'm going to show you some of the difficult scenarios, especially white cataract, intumescent cataracts, and what are the challenges we face in such cases here. So this is a white cataract here. You see here, the challenges here is basically doing a good capsular axis, which requires staining of the anterior capsule. You can see a nicely stained anterior capsule here. And needle cystotome is a good idea in intumescent cataract because the viscoelastic doesn't come out through the ports. It maintains the pressure onto the anterior capsule. So you can do a nice manipulation in these cases with white cataracts. If you use a main port and using a methyl cellulose, sometimes it can come out and the entire axis can be difficult to manipulate as such. But if you have a nicely taut anterior capsule, you can do a very nice capsular axis. You can in fact enlarge the capsular axis by a spiraling technique as such. So that gives you a very nice orientation for a subsequent surgery done. You can see there's a completion of phaco in this patient. Nice rexus has been done and implantation would be nice in such cases. So this is what is required. Sometimes you have such a high pressure where you cannot do anything. This is a patient, young patient with intumescent cataract, courtesy Dr. Namrata Sharma. You can see a nick you make here and it goes to periphery like an Argentinian flap. So it's very difficult to manage such cases. So there is no option. You may have to do a little incision here to make it a larger opening and subsequently do a emulsification. This is a soft cataract and you can very easily aspirate without causing too much a problem. The idea here is to not to allow this anterior tear to extend to posterior side. So that is very, very important issue. But luckily here we had a pressure which came down and you could still do a two semilunar capsular axis, both anterior and posteriorly, and we could complete the phaco in this patient. This is a similar video of one of a patient with a raised interlenticular pressure here. You can see which is already in a severe pressurized situation here. So once you do a nick here, it also has a tendency to go to peripheral areas. So I was thinking, what should I do to prevent, because I had used a heavy viscosity viscoelastic. I made a nick here and a nick here. So we had 4 radial cuts. So this distributed the pressure to 4 areas and it didn't go to periphery. And in the meantime, the pressure came down and subsequently you can complete this rexus despite having a high pressure. So this is not a complete rexus here. It has to go to the peripheral areas. Till the radial tear is here, it has to go peripherally and come out. So similarly, I'm trying for here to complete here, and this can be done with under a good viscoelastic cover. The idea here is to decrease the pressure by somehow. People use a 26 gauge needle directly go into the cortex and aspirate a little bit, or you can make a little puncture and aspirate. But as we saw in the previous video, we didn't have option, we didn't have time to decrease the pressure. So that should be judged by proper assessment of these patients. So I'll go beyond the cut area to complete this radial cut, which is there. A subsequent phaco becomes easier in such cases. This is another white cataract where we try the technique of aspiration in such cases. The initial staining the capsule, you can see again an intumescent cataract here. Making a nick and try to make a small opening in the capsule to a small capsular axis, so that you have a possibility to decrease the intralenticular pressure in this case. You can see that nothing is leaking out. If things are not leaking out, that means the cortex is well hydrated and this will remain pressurized during the entire surgery. So what I'm doing is doing a small circular rexus here, and subsequently I'll complete this rexus and aspirate the cortex with bimanual aspiration. Once you aspirate, the pressure goes down and subsequent enlargement or rexus can be done. Because this is a small rexus, you cannot do a phaco very comprehensively in such a small opening. And it's desirable that you make a slightly larger opening which gives you a nice access to the nucleus, and you can manage the nucleus very nicely subsequently. The idea in all these cases is to decrease the interlenticular pressure and do a subsequent phacoemulsification in these cases. This is a Morgagnian cataract. You can see entire cortex is fluid. The only option here is to automatically the fluid will get released, and make sure you do a subsequent rhexis in a clear visibility by injecting viscoelastic, and the pressure goes down in such cases. You can see the entire pressure, and we'll fill the anterior part, and the capsule will go down towards the nucleus. So you have a flat capsule, and you can do a subsequent rhexis in these cases. The phaco in such cases are relatively difficult because it will be a floating type of nucleus, and you can see a nucleus moving inside, and sometimes very difficult to chop. The idea here is to engage the nucleus in the center, hold it, then try to chop from the periphery. In fact, sometimes you can go right up to the periphery of the nucleus edge, then chop it in these cases. So these are difficult situations because the nucleus also gets harder, all these malignant type of cataract, because they are with the cataract for a long time. Nucleus gets really hard in such cases. So you have to be a little careful doing phaco in such cases, especially preventing the posterior capsular damage in subsequently when you are actually eating the pieces out, because the pieces has no epicortical cushion support for posterior capsule in these cases. The idea here is to break all the posterior attachment of this nucleus, and subsequently you can eat out piece by piece in these cases. The idea, in some cases, difficult situations for beginner at this stage, I would say stop surgery, inject viscoelastic, dispersing from your left hand so the posterior capsule remains behind, and you can emulsify the last piece in such cases. So this is one difficult situation which sometimes faced in the Indian scenario. We do have such cases. So this is what I was talking. You can do anterior segment OCT and see what type of cataract you are facing. This is a totally fluid cataract. So as soon as you make a puncture, the liquid will leak out and pressure goes down. You can have a very easy surgery in such cases. This is another patient where you have entire area is pockets. So this fluid is not going to come out with the anterior puncture. The pressure remains throughout your surgery. So this is a difficult case scenario for manual surgeries. So these cases do very well with a femtosecond application. You can see this is one of our patient, white cataract, intumescent. We are doing a femtosecond laser capsulotomy here. The amount of pressurized bag you can see here, the entire fluid comes with a gush. And this makes femtosecond application sometimes a little difficult because you still have adhesions left here. So when you take the patient for under the microscope, you make sure you realize which area would have a little bit of attachment, or that can be treated like doing a manual rhexis. And this gentle movement will have a complete capsulotomy in difficult white cataract also. So these are small things which are important for these cases. If you take a consideration of raised pressure and how to decrease the pressure when you are doing a capsulotomy or capsulorhexis, the results of a white cataract surgery also is quite good in those cases. Thank you for your kind listening, and we would like to invite Dr.